Thank you very much, everybody, for coming. So I guess in this part, we're going to just talk amongst ourselves, hopefully questions that are important to the audience here. And I want to thank again the myeloma crowd for coming here for the third time, and hopefully this will be the third of many more times to come. And I also want to thank my colleagues here, and especially those that have arrived here from other parts of the country. Dr. Bob. So I was saying Bob here, gives a great history of multiple myeloma. What he always leaves out of it is his tremendous contributions to multiple myeloma. He's the person that the experts go to when they need advice. He's humble, and I was honored last year when we had fellows from all over the country, people in training, that I was able to chair a session in Tampa, Florida, where we honored Bob on his 90th birthday. And we look forward to, I told him there, honoring him on his centenary, because he still clocks hundreds of thousands of miles every year because everybody wants him to give input on myeloma. So thank you, Bob, for coming here. It's a privilege. And we have, obviously, Dr. Krishnan, who has chaired the transplant committee for myeloma here in the United States and has been instrumental in some of the largest transplant trials that have been done. And she spoke elegantly about transplant. And then, obviously, Tanya is my colleague, and she obviously has built up a national reputation in care of myeloma in older individuals. There are very few people that have, that skill set. Tanya trained both in cancer and in care of the elderly. She's boarded in two different disciplines, so I don't think that came out in all the talks that were given, that nobody talked about what they've done, and they've done tremendous. But again, having said that, I think we're going to go ahead and move on to some of the things that get asked among us clinicians very often, and patients too. So we, Bob, have certainly come a long ways since rhubarb peels in treating myeloma. And we've seen an explosion of therapies and transplant. Now, the thing is that we're hopefully entering an era where we can start to individualize treatments. And one of the things that we often hear about in that regard is, that other disease states have moved into not treating myeloma as one paradigm. What is your view on how you think on your centenary celebration you'll be talking about myeloma?
Well, it's impossible to answer that question simply because I have never seen two patients with multiple myeloma who are exactly the same. Every person is different. We do know that each and every one of you has had a monoclonal protein in your blood or in your urine prior to your development of multiple myeloma. Now, this protein has been present for probably an average of 10 to 15 years at least before it is recognized. However, today, don't feel badly, because there isn't anything that we can, or, well, that we should, certainly, or that we can do because you have that protein abnormality. And this brings up one of the points that was made this morning in the iceberg slide, in which we used to see very large icebergs. And if we could get that iceberg down to zero, that is to sea level, we were very, very happy. But as we have learned more, there are more and more cells under the surface. And so we're digging deeper and deeper and killing more cells. Okay, I've often wondered what happens when we get to that very first cell, and that very first cell is gone. In other words, there theoretically, isn't a single abnormal cell in a person's body, from that standpoint at least. Is that patient actually cured? And we don't know that. What happened to that very first cell that you got that in turn multiplied and after many years developed symptomatic multiple myeloma? What happened initially? And we don't know that. Is there something that was this just perchance, or is there something happened that caused all this? I'd like to ask my learned colleagues here in front of you to answer that question, because I can't.
Now, there's certainly a lot of unknowns, and I think that Bob said it aptly. We're always learning, and hopefully he will come to answering some of the questions he has posed. So I think that one of the things I'll ask now, Amita, is that obviously you gave a good, very good overview about transplant and its role. And the fact is that transplant is something that you said can be done in older and older individuals. However, I think that one of the things we need to also be cognizant of is that not everybody, even if they're 70, is a candidate for transplant. So just could you hazard to comment a little bit about what's happened in those who cannot get a transplant, how they're doing now?
So I think that is actually some of the biggest advances we've made. I mean, even as transplanters, we have to recognize that now outcomes of people who also, for other reasons, potentially what we call comorbidities, other issues that make transplant less safe for them, there are a lot of new drugs, and I think the one I'm the most excited about is the combination of the daratumumab, so the monoclonal antibody plus lenalidomide, that Dr. Wilder talked about, the Maya trial that came out last year, that looked at that combination and showed extremely high response rates, including patients becoming this concept of MRD negative on it. And we use a lot of daratumumab. We were part of the center that did the early studies with it. And once you get beyond the initial infusions in terms of time, it's find it generally quite well tolerated. So I think the take-home message is even if you don't get a transplant, we can still get very good outcomes for many people.
Thank you. So Tanya, so I guess in terms of older individuals, you're obviously one of the leading experts in that area. So I think I'll try that in with high-risk disease. So high-risk disease, how would you encompass that? Obviously, a lot of people talk about it in terms of chromosomal features, but there are other patient features as well. But if you could also address some of the traditional high-risk features of myeloma and how we kind of are trying to go about treating those patients.
Perfect. So I think Robbie's been reading the agenda for the American Society of Clinical Oncology meeting in 2 weeks, where I'm giving a talk on this very setting. And in that talk, I'm planning to talk about traditional features that are used to define patients who are considered high risk. And those include the staging system we currently use. We currently use the revised international staging system, which is a combination of some blood levels of blood albumin level, the beta-2 microglobulin, lactate dehydrogenase, also called LDH, and then folding in those chromosome changes, the changes in the DNA packet in the myeloma cells. And then there's emerging use of things like gene expression profiling and sequencing and things like that that tell us about the cancer that itself is going to be more likely to behave badly, to become active again shortly after treatment, that sort of thing. But as someone who focuses on myeloma in older adults, one of the features that I balance against that is what are the features of the individual that makes them at higher risk? And one of the questions we ask is at high risk for what? For the myeloma becoming active or for side effects of treatment? So in an older individual, we know factors that may make them at greater risk for tolerating the treatment poorly. And meaning that we would have to discontinue treatment shortly after starting it, which clearly is not going to control the myeloma well if we have to stop the treatment early. So sometimes we have to come to kind of the crossroads of how aggressive can we treat the myeloma balanced against, particularly in an older adult, what are our chances of them not tolerating this treatment well? And sometimes that's hard to find that exact sweet spot between treating the myeloma more aggressively with their chances of having toxicity of therapy. As Dr. Christian pointed out, the good news is we're getting some of these really well-tolerated treatments like daratumumab available to us in our war chest earlier and earlier. So if we can give a well-tolerated treatment that really packs a punch against a higher risk behaving disease, but then has a well-tolerated side effect profile, that's going to help us find that sweet spot.
Great. So turning to you, Amrita, again. So as far as your efforts go for genetically high-risk disease, first of all, how would you define that, and how are you thinking about trying to alter the paradigm in the years to come?
So, we still tend to use the FISH test as, and I think that, some of the other speakers had mentioned it in terms of those groups that are defined by FISH testing as high risk. We are trying to be a little bit more sophisticated about that. For example, a 17p deletion has been classically a high-risk feature, but there's certain, not every 17p patient, for example, as you know, if you look at the COMPASS study, defined that patients who lose both copies of 17p are more high risk than patients who have just lost one copy. So trying to be a little bit more sophisticated about that. But in terms of treatment, I'd say what we're really trying to focus on is what is the therapy you do after the transplant to help prevent relapse? Because patients with high-risk disease will respond to treatment often as well as patients who have standard risk disease, but it's more the challenge of staying in those responses. And I think the one I'm most excited is about the CAR T, actually, up front. I mean, that was many years of convincing. The patients were ready, they recognize that clearly, but it's convincing the companies to also get on board with that, and they now have, and that we're going to open that this year. So I think that's probably very exciting for us.
Yeah, I think that there are a number of efforts afoot to try to compartmentalize myeloma into different subgroups. I think in at least 10 years from now, hopefully we won't be talking about myeloma as a uniform disease. At the genetic level, we know it's a very different disease, and we know that some people can remain in remission for 10 plus years. Others, unfortunately, comes back within a year. So these are things that we know at the genetic level are different, and I think we're just entering an era where we're starting to unravel how to go about developing distinct treatment paradigms for these different groups of patients. And hopefully in a few years, if we have a myeloma crowd roundtable, we'll be talking about how to treat this risk patient and that risk patient, which we don't do as much these days. Right now, for high-risk disease, most of the people will, after a transplant, talk about dual maintenance therapy. The initial treatment, it is felt that the 3-drug regimen is pretty standard, whether you're high risk or not. But yeah, the other thing we know is that a lot of these chromosomal abnormalities are present right at the earliest stage of the disease, and I think that we'll briefly touch upon that here as well, because myeloma, as Dr. Kyle just said, that doesn't evolve within a year or two. And the person who showed us that is Dr. Kyle himself, who in the 1960s had the foresight to actually start collecting samples, and he's got now the world's largest registry of samples from patients in myeloma, and I think probably more than 200 myeloma experts in the last 50 years have gone through his training to be able to use that to further understand the evolution of myeloma. And I think this is just the two categories of disease, MGUS and smoldering myeloma, that some of you obviously have heard of, but I'll have Bob expand a little bit. So Bob, what about the entities that you named and the ones that have stood this test of time? Patients with MGUS, patients with smoldering myeloma, how do we tackle this group of patients? And does everybody go through this phase before they arrive at myeloma?
Well, let me say a few words about the first patient. I've oftentimes made the comment that patients have taught me everything I know. And this particular patient did. It was a woman who came to the Mayo Clinic in 1964 and had a full-blown multiple myeloma, anemia, bone pain, lytic lesions, many plasma cells in the bone marrow, the whole picture. Well, at our institution, we have the previous visits of patients' records in the packet, in the folder of the one that we see. And I looked at that, and this woman had been to the clinic 20 years or 19 years before, at which time she was aged 45 and complained of fatigue. She was tired. And so the physician who saw her did the usual CBC blood tests and a test called the sedimentation rate, which isn't done very much anymore, but it was a screening test to kind of give the physician an idea of could there be something hidden. Well, this woman had a sedimentation rate of over 100 millimeters per hour, which is a major league abnormality. And the physician seeing her did the conventional tests. They were all normal except for the sed rate, and with that, he ordered an albumin-globulin ratio. The globulin was elevated, but there wasn't anything else to do at that particular time. Patient went home after being told that, well, can't find anything awry, and came back 13 years later, at which time she was feeling quite well, and her laboratory tests were all normal, but now a serum protein electrophoretic pattern was made, and the patient had a very large spike. It was something in the neighborhood of 2.9 grams per deciliter, major league spike. But she was asymptomatic, no other abnormalities, and she was patted on the back again and said, you are doing well. And then when she came back the third time, she had the full-blown multiple myeloma that I described to you. And so recognizing this story, I kept my eyes open for others, and actually others appeared, and was able to collect 241 of these individuals and published it and called it, I didn't know what to call it, and I called it monoclonal gammopathy, and I used the term undetermined significance, but probably in retrospect a better name would have been unknown significance, because it was determined by this protein per se. But this was the start of things as far as I know, and today we see there are many patients. You aren't the only ones with a MGUS, a MGUS or a MUGUS. It involves 3% of the population above the age of 70 years, and the vast majority of these patients, it's of no consequence to them, because unfortunately at age 70, you don't have as long to go as that person who is 40 years of age or 20 years of age. And so many patients will die of stroke, heart disease, other malignancies that are totally related to the monoclonal protein. But there is a small number, represented by you individuals, who have had or who have developed the consequences of a monoclonal gammopathy. And what I think we need to figure out, which of these monoclonal gammopathies, oh sure, we've got a whole bunch of criteria, the size of the monoclonal protein, the type, whether it's G or A or M, or even D or E. There's actually been an IgE mugus that's been reported. We've only seen 5 cases of IgE multiple myeloma at the Mayo Clinic since 1960. So any IgEs are rare birds. And I don't know, have any of the panelists seen an IgE myeloma? Yeah. Well, goes to show you, it's a rare business. But anyway, kind of keep that in mind. And if a person has an MGUS or a MUGUS, it's certainly not the end of the world for that patient. And nowadays, when a patient has multiple myeloma, it's far, far, far from the end of the world. And I am very optimistic personally that we're going to see some very, very important advances in the next decade. And people will look back and say, gee, it's not such a bad thing after all. I mean, look, pneumococcal pneumonia was called the old man's friend in the 1930s before penicillin. And the elderly, and it was more males than females who would get a pneumococcal pneumonia. On the 7th day, they would either defluoresce, that is, the fever would disappear, they'd have a big sweat and so forth, or they would pass away. And along came penicillin, and holy smoke, pneumococcal pneumonia almost disappeared. We still see it, but we can do more about it now. Anyway, that's enough of this.
Well, as you heard from a living legend, he obviously saw penicillin come to the world. And so I will now turn it over to Greg for taking questions, I think, from the audience.
So clearly the number one risk factor for myeloma is age. And with the aging of the population, we're seeing an increasing number of cases overall. The average age, depending on the study and population looked at, is probably 71. So obviously not the case in your case. As far as environmental exposures and things like that, those studies are really hard to do. And so a lot of them, we can find linkages, but then somebody can find another reason why that wouldn't explain, the causation. We often get asked about family histories of myeloma. By and large, most people do not have a family history, but occasionally we will find a patient who will mention, they'll come and see me and say, well, my sister sees Dr. Vidge, or my cousin is up in Illinois, and we try and find those families and bank their specimens to try and understand what genetic links there are. But great question. We'll see some segregation of other similar blood, or I call them second cousin diseases like lymphoma. We'll sometimes see some clustering, but again, there's no screening test to look for from lymphoma. And we will often hear too, some families say, should my children be tested? And I usually do what we call shared decision making, which is talk through the pluses and minuses of them looking for the M spike. And Dr. Kyle, you may be able to speak to this as well. What I typically share is, because this disease is, I should say, the protein is present in 3% of people anyway, and then we don't know that person who has a monoclonal protein will go on to develop myeloma. It comes down to, how would that knowledge impact that person? How much of a burden would it be to know that it's there versus would it be empowering for them to know? And that's a very individual question about how that knowledge would impact them. Dr. Kyle, do you have any comments?
Oh, yes, of course. First of all, the age of patients with MGUS or MUGUS is roughly the same as multiple myeloma. In both instances, 98% of the individuals are above the age of 40 years. And this number keeps going up at least into the high 80s when a male in the upper 80s has a risk of, I think it was, in our studies, it was 8.7%. So it's very common in the older patients. 5% of persons above the age of 70 years have an MGUS. And the same is true of all of these. Now, there's a big spread, and I had the privilege of seeing the youngest MGUS patient that I have ever seen 3 months ago. We have in our database 33,000 MGUS patients, okay? This boy is 8 years old. And and I saw him with the pediatricians, of course, because 8-year-olds, we don't see, none of us see much for 8-year-olds unless they're your children or grandchildren. And so the mother, who was very astute, after I'd talked to her about her experience with the increasing incidence and so forth, and she said, well, on the basis of that curve, my son is very likely to have multiple myeloma by the time he's 60 years of age. And I said, well, I don't know. And we just have to keep watching. And that's the case with every MGUS patient. You gotta follow them and see what happens and catch them before they develop bone lesions from myeloma or kidney failure from the progression of the disease, fractures and all of that sort of thing. So it's very interesting, and here I've been looking at this stuff for 40, 60 years, and here comes an 8-year-old boy with MGUS.
I did want to add, I think some of the questions you sort of are asking seem to be in terms of what are the risk factors in terms of, so we do have something in California, it's called the California Teacher Study. So we followed, and it was funded by the NCI, 100,000 teachers over the span of 20 years. And a lot of the questions were in the lifestyle questions. So our pop sci division is the one who houses that data, and it's a very extensive questionnaire, just self-reported, kind of a lot of what you're doing with HealthTree, actually. Questions like how often do you exercise, what other medicines are you taking, what are you, food, diet, family history, all those things put in there. So from the California Teachers Health Study, they've done a lot of work with breast cancer because most of the teachers are women, right, especially 20 years ago. But the other thing they did find from myeloma, and we published this last year, was there was a slight association, and again, slight is the issue, but something we're interested in, diabetes, and a slightly higher risk in people with diabetes to have a monoclonal gammopathy, and then also myeloma. Interestingly, some of the drugs you take for diabetes, such as metformin, seem to have protective effects. So it's hard to always, these things aren't always clear, but it is something that we are very interested in. These are the kind of studies you can only answer through very, very large numbers of people. So what you're doing as part of the HealthTree, for example, is actually stuff that we all want to then look at because for these very reasons. So I think all of us probably have 1 or 2 patients who have 2 cancers at the same time. I mean, some of it speaks to just the biology of the disease coming from the precursor cells. And I'd be interested to see what other people's approaches are. I would say from the transplant standpoint, what we have generally done for those cases is use a regimen. But so the nice thing is autologous transplant is also a mainstay in lymphoma for a certain. So we tend to use a regimen that will probably cover both. So there is some overlap with some of the drugs. So you try and kill two birds with one stone.
Yeah, and I think that, again, lymphoma is a broad diagnosis. There are several subtypes of lymphoma. Some are actually curable with a stem cell transplant. Others could be helpful but may not be cured with a stem cell transplant. So I think without knowing the details, it's difficult to say for sure. But as Amrita said here, a stem cell transplant can at least help both diseases often.
So the question was, in a person who has lost a lot of weight leading up to their diagnosis and hasn't regained it, will they regain that weight? A few factors will go into that. Number one, when cancer is very active, there's just a state of muscle breakdown that can result in a patient losing weight, even with what might seem to be adequate calorie intake. Other things that can influence weight loss are side effects of the treatment, impacting appetite, taste buds, nausea, all of these sorts of factors. So when I approach a patient who is concerned about their nutrition, the first place I start with are the simple things. How is their taste? I mean, we don't see it in our research studies because it's not considered a kind of serious adverse event, but I have patients on Revlimid long-term who complain that their taste buds are just not right. And so there's some simple tricks to try and find what works for an individual as far as taste. When a patient complains of poor appetite, I really dig into whether that's related to nausea or is it truly just not being interested in food, and then I look at what might underlie poor appetite overall. Depression is one of the most under-recognized contributors to poor appetite. And then we want to think about the weight loss. Is it good lean muscle mass, and what is a healthy weight for a person? And so I kind of fold all that into the considerations about what is a healthy weight, what is their healthy nutrition. We'll work with our colleagues who are registered dietitians to look at a person's intake to make sure they're getting the good balance of protein and healthy fats and those sorts of things. That brings it to another commonly asked question is, what diet should I be on? Is there some sort of special diet? I've heard that sugar feeds cancer. That's a common question that we hear. And the bottom line is there's no one single right answer to that. And there certainly in myeloma itself, there's not any specifics. There's some patterns that we'll pick up. People have talked about curcumin and that sort of thing. I think the best evidence for diet overall is for a Mediterranean type diet, which is lean meats, more protein from fresh fruits and vegetables rather than animal sources, lots of fresh fruits and vegetables, that sort of thing. And it looks like Amrita's got a thought.
No, I was going to say, really, my diet question, I want to ask Dr. Kyle, what is this diet recommendation? Oh, you don't want to eat what I eat, trust me.
There was a question just a few minutes ago about family history of multiple myeloma. And we have looked at this somewhat extensively and have come to the conclusion that the risk of multiple myeloma in a family that in the first degree relatives, and that is parents, children, or siblings, have about a twofold, about a double risk of developing multiple myeloma. And when a patient asks that question and they say, oh, my risk is twice as great as the normal population, oh, that's terrible, terrible. And then I emphasize to them that what this really means is that the risk of multiple myeloma is, instead of being, say, 5 cases per 100,000 population per year, it's 10 patients per 100,000 population per year. And when you look at it that way, it doesn't really add very much. And yeah, it is a straw in the wind, so to speak, but just because you have that first-degree relative with myeloma, it's unlikely that there are going to be others in your family. It's not an epidemic.
Anything about diet?
Oh, not really. I tell patients just simply to follow a normal, healthy diet that a dietitian or your doctor or anybody like that would tell you. Eating this or that is not going to make any difference. Maintain your normal weight, and of course, the Mediterranean diet is probably the most healthy we have, but I don't think there are too many people that really follow that strictly. Personally, I eat 2 bananas a day.
That's what I wanted to know.
Before we get to our so I've got a great piece of advice if you want to gain weight. Yesterday I had ribs, burnt ends, fried pork skin, and coleslaw at Bogart's, and that put on some pounds.
I do have to make a comment. You know, the Indian diet's pretty darn good. We eat a lot of lentils and vegetables, so I don't know why the Mediterraneans get all the credit. So.
The question, I think, is metabolism, attacking the metabolism of the cancer cell to, correct. Yeah, so I think that that's a good question, and somebody told me when a speaker starts answering the question with "that's a good question," it has no answer. The fact is that we are increasingly now, in not only myeloma, in a lot of other cancers, finding that the metabolism of the cancer cell is very different than that of the normal cell. And there are drugs that are being purposed for that. In leukemia, for example, there's a set of drugs called IDH1, IDH2 inhibitors. They actually work through altering the metabolism of the cell. Likewise, in myeloma too, as in other cancers, this is an area of active research. I don't think that we have a definitive answer, but there are companies that are testing drugs to alter the metabolism of the myeloma cell. Anybody else wants to take a stab at that? So I think you're referring to having blood samples from individuals with cancer?
Yes, with the myeloma, and it's going to be in a registry to help out other patients and stuff like that.
Sure. So the thing is, there are numerous registries out there. We at Washington University have one of the larger registries to study the genetics of multiple myeloma, but then there are moves afoot by other not-for-profit organizations as well that are doing this. So yes, there are a number of registries out there, and each is starting to produce data. And I think that we are starting to probably talk a little bit later in the afternoon session on how some of this data is coming to the fore. But for those who have doctors here at Washington University especially, we actually encourage people to bank their specimens in our registry as well, and we collaborate with other registries as well to send samples with your permission to other registries. So there are a number of registry efforts ongoing. Yeah, so I think I'll quick stab at that and see if any of my colleagues want to address that. So I think that we're just now starting to unravel the risk predisposition to multiple myeloma. So BRCA1 is a gene that predisposes you to multiple myeloma. At the Mayo Clinic, actually, they have a big registry of people from family members who have multiple myeloma. And I don't think even Bob knows this, but we're actually collaborating with them because we have now the power to actually analyze the whole genomes here at Washington University of all these family members. So we're actually, as we speak, analyzing that data, and maybe in a few months there will be something that one can answer as to whether we've found some hereditary predisposition factors. So that tells you the power of collaboration. Bob and his university have built this registry over decades, and now we have at Washington University people who have the ability to analyze this data. So I'll take a stab at that, and then I'll give it to Bob as well. So Bob, the question is that for patients, even before they develop MGUS, is that what your question is? Like, how do we prevent a normal plasma cell from developing into an MGUS cell that goes on to develop myeloma? And I would say that that is something that is still the subject of active investigation. One thing that has been found in the last few years is that a disease called Gaucher's disease has got a higher risk of developing patients developing these abnormal proteins. And this is a very rare genetic abnormality, and it is thought that in that disease, it is because of abnormal lipids that the body recognizes that causes an inflammation, trying to simplify this very simply, and maybe that is what sets off the initial insult. But having said that, at the genetic level, trying to answer this once again, we have in the last few months only, actually, here at Washington University, and we've submitted a paper that is at review at a major journal, maybe the first time that we can actually genetically show that the cells evolved from normal cells to pre-myeloma cells to the malignant cell. But having said that, Bob, what is your take on how to prevent MGUS?
Well, that is definitely beyond me, and I think that it's obviously a very good and a very important question, but we need to continue to look at these people and see if there is anything in their genetic makeup that would predispose them to various factors. As you probably know, overall, persons who are exposed to chemicals and there are a couple of hundred papers on the epidemiology of multiple myeloma related to various substances, everything from black hair dye to carbon monoxide to all sorts of fertilizers, chemicals, weed killers, and all of those sorts of things. And there are people who are just overexposed to some of these things and nothing happens to them, and then the next person is susceptible to something like this. So I think we get back to the genome of the individual patient as playing a role, but we still don't understand what that is specifically.
So I guess to kind of frame it more broadly, the questions seem to center around, number one, side effects and how to manage that in the maintenance setting and what's the optimal choice of drugs. And then the second one in regards to heat, really, and is that beneficial in terms of treating myeloma? So in terms of side effects, this again comes down to the one size doesn't fit all, and other patients I have on carfilzomib or Kyprolis as a maintenance strategy, yes. Are there patients who are unable to tolerate Revlimid? I have some patients, I'm sure we all do, have extreme hypersensitivity. One of them, literally, given one dose, his eyes will swell shut and his face will blow up. I mean, so we're clearly not going to use Revlimid maintenance for him. Another patient who, so the fortunate thing is we have all these other drug options now. So do I have patients on Kyprolis maintenance? Yes. Patients on daratumumab maintenance? Yes. Sometimes you have to do it in the absence of yet having all the data. So sometimes myeloma therapy is like cooking. You have to sort of make up your own special recipe for a patient. In regards to the heat question, I've never heard that. The one thing I would say is, again, fortunate living in California and not Rochester, Minnesota, cold, I seem to find patients, and again, our version of cold is very different from Dr. Kyle's version of cold. When it hits 50 degrees, we're wearing our down jackets, we're wearing our gloves, and patients do find neuropathy seems to be worse in the cold.
Yeah, I think that again, Velcade is well known to cause neuropathy, unfortunately, and there are actually certain, research grade tests that people have even developed to pinpoint who could potentially get neuropathy with Velcade, but those are not commercial tests; those are just research tests. I think that one of the things with Velcade is that when we give it in the maintenance setting, we often give it twice a month. And that often has low risk of neuropathy, but I'm not by any means saying that that cannot cause neuropathy. The other drug that we sometimes use in the maintenance setting these days is ixazomib, which is a pill, which also has some chances of neuropathy, not as bad as Velcade. And so that is another drug that we sometimes use in patients where we can't give them Velcade or give them Revlimid, but then it's not approved for myeloma maintenance, and some insurance companies will often deny it. So I think that's a vexing scenario. Do you have anything to add?
I would just like to mention one thing about neuropathy, which was brought up a minute ago, and that is there was a study some years ago of a group of patients above the age of 70 years. And these patients were all completely asymptomatic, and secondly, were examined by a very good peripheral nerve neurologist, and he found no abnormalities. Well, they did EMG studies on these individuals, and about 25% of them had early changes consistent with early peripheral neuropathy. And I wonder if that is, I think that that's an important observation, because we've all seen patients who have been put on Velcade, and gee, after just a very few injections of the drug, they're complaining of paresthesias and features of peripheral neuropathy. And I just wonder if some of those patients aren't the individuals who have the subclinical peripheral neuropathy, and then you give them a drug which does have neurotoxic features, and given to that person, they get peripheral neuropathy very quickly, whereas the next person down the road doesn't get it for ages. And I've seen patients that have been on Velcade for a long time, and I've questioned them. No, I have no numbness, I have no tingling, I have no symptoms whatsoever. So I think a lot of or some of this at least, is in the individual.